I wanted to thank everybody for attending, and definitely thank Dr. Manar and Dr. Rahab for always helping us organize these, as well as our organization's coordinators, Mustafa and Kareem. Today, we have Dr. Dua Fouda is starting her first presentation with us on the tumor board. Welcome, everybody.
Our pleasure, Dr. Mohammed.
Do you hear me? Shall I start?
Could you raise your voice, Dua?
Shall I start?
Yes, please, go ahead.
Okay. So our case presentation is about a 46-year-old gentleman first presented at our patient clinic in March 2022, complaining of progressive B symptoms for 1 month post-booster dose AstraZeneca vaccine. So about the examination, our patient was vitally stable, no organomegaly or lymphadenopathy apart from dull tropes area. The lab CBC, the total leukocytic count was 6 with normal differential leukocytic count, while hemoglobin was 5, normocytic normochromic anemia. The platelet was about 19,000 with normal function test and normal function test. The direct home test was negative. The LDH was high, about 684 from reference 100, 180. The reticulocytic count was 2% with normal coagulation profile. Viral markers for HCV, HIV, hepatitis B virus, cytomegalovirus, Epstein-Barr virus was negative. So we do bone marrow. The bone marrow aspirate was diluted with frequent blast cells in the bone marrow and the peripheral. The bone marrow biopsy was hypercellular bone marrow, about 30% cellularity, was detected fibrosis associated with suppressed series with no increase in the blast cells. Immune histochemistry showed plasma cells about 15% was positive for CD138 and 5% was positive for CD56. CD100 and 117 highlight about 2% with few plasma cells, CD23 positive in 30% of histiocytic reflection, CK was negative. So we do the multiple myeloma workup to exclude if a patient with plasma cell dyskeriosis from these plasma cells was positive for CD1. So we do serum protein electrophoresis and immune fixation, and they were normal. The whole body skeleton CT showed diffuse osteopenia. Otherwise, there was no sclerotic or lytic lesion. We do a pan CT or CT scan of the chest, abdomen, and pelvis with contrast. It showed only splenomegaly about 14 centimeters and reactive axillary lymph node only. So during our follow-up, our patient, a second bone marrow aspirate and biopsy were required for further evaluation. The second bone marrow aspirate was very difficult aspiration, showing hypocellular aspirate with dysplastic erythropoiesis, with marked histiocytic proliferation with increase in the activity of macrophages, showing hemophagocytic activity occupying about 25% of the cells. The second bone marrow biopsy was marked hypocellular bone marrow biopsy with total depression of all hematopoietic series lineage with predominance of macrophages showing hemophagocytic activity, and it was a picture suggestive of secondary hemophagocytic lymphohistiocytosis with associated myelofibrosis grade 1. So for further clarification of nature of the disease, we asked for revision of the second bone marrow biopsy and revealed marked hypocellular bone marrow showing total depression of hematopoietic cellular lineage with predominance of macrophages showing hemophagocytic activity. Only rare hotspot of hematopoiesis seen. This process was associated with grade 1 fibrosis according to the WHO criteria. The immune histochemistry for CD138 highlight about 30% of the plasma cells. MPO was positive in the residual myeloid elements in about 25% of the cellularity, while CD68 highlight about 15 to 20% of the histiocyte. So we asked for hemophagocytic lymphohistiocyte workup. We asked for soluble CD25, but it came in a percentage about 25%. The ferritin was high, about 600 from reference 200 to 400. However, fibrinogen, triglyceride, bilirubin were normal. So our patient accordingly for the splenomegaly, for the hyperferritinemia, the cytopenia, the hemophagocytic activity in the bone marrow, started the HLH protocol, which included the Vipset, cyclosporin, and steroid, about 2 weeks with no improvement in the cytopenia or symptoms, unfortunately. So we asked for another HLH and bone marrow aspirate and biopsy done for more clarification of the disease nature, and revealed the new bone marrow aspirate was diluted. New bone marrow biopsy examination of the prepared section from a specimen revealed bone marrow trabecularly separated by bone marrow spaces showing hypocellularity for age, about 20 to 30% of the cellularity. All series are detected but reduced. There is no detected
Hello.
abnormal deposit. Immune histochemistry CD3 20 117
كنت نايم
34 show
ايه
negative reaction.
ان شاء الله.
The MBO delineate minute cells. So we asked for immune phenotyping was done on the bone marrow sample, show 60% of lymphocytes and 57% of them express CD7, 15% of them express CD19, and 5% was them for CD45 mononuclear cells express CD34, 117, 33, and negative for CD10, 19, 38. The conclusion was a normal lymphocyte immunophenotyping pattern with few myeloblasts, about 5% for cytogenetic study. About the HLH protocol, the new fibrinogen was about 300, which is normal from reference 200 to 400. The ferritin was high, 676. Triglyceride was normal, about 85. It's normal up to 150. The bilirubin was normal also, 0.7 from reference 0.3 to 1.2. And we asked also for soluble CD25 because in the first time it was done in percentage. It became 2,453 from reference 610 and 2,060 626. So about the diagnostic criteria of hemophagocytic lymphohistiocytosis, it included 5 of the following 9 findings: fever equal or more than 38.5, splenomegaly, peripheral blood cytopenia with at least 2 of the following: hemoglobin is less than 9 grams per deciliter, the platelet less than 100,000, absolute neutrophilic count is less than 100 per microliter, hypertriglyceridemia more than 265 milligram per deciliter, and the hypophybrinogenemia less than 150 milligram per deciliter, hemophagocytosis in bone marrow, spleen, lymph node, or liver, low or absent natural killer cell activity, ferritin more than 500 nanogram per milliliter, elevated soluble CD25 to standard deviations above age, adjusted laboratory specific norms. So if it was less than 2,400 units per milliliter is helpful for ruling out HLH sensitivity about 100%. And if it's more than 10,000 units per milliliter is helpful for ruling it in, specificity about 93%, elevated CXCL9. So the treatment protocol of our patient finished the 8 months of HLH protocol on 8 weeks of HLH protocol on 21 of June, including Vipset, cyclosporin, and steroid without improvement in constitutional symptoms or cytopenia. So the patient shifted to ruxolitinib, Jakavi, starting in 17 of July of this month, and showed a little increase in the platelet count. About it was always less than 10,000, so it became about 18,000, 20,000. And our patient always showed the leukopenia and thrombocytopenia without need of the transfusion of backed RBCs. Thank you. This is all.
Thank you, Dr. Dina. I just have a few questions. So did the patient meet criteria for HLH if you
Yes.
look through all 9, and despite the absence of the the soluble CD25 was not fitting, right?
No,
Yeah, it was
no,
low.
it's the soluble CD25, it's 2,453. And about the diagnostic criteria for HLH, it included when the soluble CD25 is less than 2,400, it's helpful for rolling out. So it's more than 2,400. Our patient really meets the criteria for HLH because he has fever, which is more than 38.5. He has a spleen, he has peripheral cytopenia, and 3 lineage. And also he has an hemocytosis in the bone marrow, which is the 4th criteria, and also has an increase in the ferritin more than 500 with elevated soluble CD20. So he has 6 criteria from the 9, and it's 5 or more than this. So he meets the criteria really of the HLH.
Yeah, I mean, the problem is the criteria that we use for HLH overlaps with a lot of like inflammatory things in general. So if you have someone with lupus, for example, you're going to see cytopenia, splenomegaly, fevers. The hemophagocytosis in the bone marrow is neither sensitive nor specific for HLH specifically. So it's usually it's hard to diagnose usually HLH, but with those numbers, I agree with Dr. Higazi, it's questionable if it's HLH. But let me just ask you a question. So for this severe anemia, like what kind of anemia is it? Is there hemolysis? Is it normocytic? Is it what kind of anemia is this?
Yeah, it's normocytic normochromic anemia.
Did we have hemolysis, labs, and haptoglobin and LDH and things?
Yes, the direct hemolysis was negative, bilirubin was normal, serum haptoglobin was normal, and the LDH was high, about 600 from reference 200 to 400.
Oh, okay. And did you have a reticulocyte count?
Yes, it was about 2%.
Okay, 2% for this degree of anemia. That's that's low. So the bone marrow is not producing much. So it's not like a peripheral destruction, because the other thing was like, PNH, which could present like this, but it's usually hemolytic in nature. And the, I don't know, Dr. Higazi, I think, I'm not sure if it's like a bone marrow issue.
No, I wonder.
We had like a flow cytometry, and like I think the slide before last had a flow cytometry on it, right?
Yes.
Yeah, I wonder what Dr. Alqua's take from the pathology side of things.
So with the HLH is a it's mostly diagnosis by morphology. The flow is not going to be that helpful unless it's extremely exuberant. I have never seen flow be even used, and the role of bone marrow is simply just one of the criteria getting checked. So it's not a major thing. Usually just raise suspicion, and that's probably it.
Yeah. No, we were not talking about flow as to diagnose HLH. We're looking for other things. Like, could this be like a TLGL or some kind of like another, there's like the question is just making a diagnosis.
With LGL, I I mean, I'm not seeing the 57 on there. LGL is a little tricky because it's a bunch of things, and they're not always present in every LGL proliferation, because LGL it overlaps sometimes with NK proliferations. So I'm not seeing. I mean, here it says 60% are lymphocytes. And the majority of them express 7, which is normal. Some loss of 7 is okay. And then 15 are B. I don't see anything that jumps at me, and it's abnormal, really.
We
Yeah.
have Dr. Zahra with us.
Okay.
She can
Can
present the slides. Zahra?
Can I have comment? Can I add
Yes,
comment?
please.
Okay. Okay. Good evening, everybody. Thanks, Dua. Good presentation. But I think this patient didn't follow the criteria for HLH. For CD25 should be above 2,500. Below 2,400, it rule out, but not diagnostic. Okay. So for this patient, I even workup not. I think we should add other microbiological tests, other immune profile. I think maybe other test needed to complete workup. For routine, even it is above 500, but it is not too much increased. HLH cell can be even reactive within inflammatory process alone, not يعني much directing towards HLH. So I think we should search for another etiology for the patient symptoms, fever and constitutional symptoms. That's my point of view.
Yeah, I fully agree.
Yes, agreed. I'm sorry, I didn't know that we have the pathology also to be shared with us. Dr. Zahra, please go ahead. You might be muted. Dr. Zahra, if you're speaking, I don't think we can hear you.
Can you hear me now?
Yes, yes.
Yeah, I want to present this pulmonary biopsy. The biopsy is actually really weird. It's very markedly hypocellular. It looks like it has a lot of fibrosis, but the reticulin at the end is like grade 1, which does not match the morphology. It's very hypocellular, but we can see here in the second slide that there are macrophages that are engulfing cells. So it's hemophagocytic activity. We can see it in the second and third slide and the fourth slide. We have these cells that look plasmacytic. They are positive for CD38, about 30% of cellularity. But as I know that you performed clonality and was polyclonal. CD68 was positive in macrophages, so we don't have really anything else to say other than it's really markedly hypocellular for unknown reasons.
Yeah. And how old is the patient? Dr. Dara, can you remind me, please? How old was this patient?
He is 46.
46. So, to think of it as a primary HLH in a 46 years old is also very difficult. Even if you do believe that this is HLH, there is something else underlying causing this. I'm not sold that this is HLH. Personally, I don't know if Dr. Muhammad Awad, Dr. Emmons would also like to weigh in, but I think there's an underlying etiology to this whole thing, and it is not a pure HLH, if it is even HLH diagnosis.
I would agree with you, Mo. I think, typically HLH is associated with ferritins in the thousands and also very high soluble CD2 levels. So That doesn't fit. The splenomegaly certainly can, although it's not massive splenomegaly, and that by itself, of course, can cause some degree of cytopenia depending on the underlying etiology. As to whether there is a background T cell clone that's causing problem or potentially a primary myelofibrosis clone causing problems, I don't know if you ever send off next generation sequencing on the marrow in situations like this to try to get a better clue as to whether there might be a clonal population hiding in this sort of hypocellular situation. Staying in the marrows of patients who are fibrotic is often fraught with difficulty because there's differences depending on where you put the needle around the skeleton. So you might get a very different result poking one place versus another. Occasionally in confusing cases like this, MRI is helpful because it can show you pockets of different fibrosis versus marrow. You might be surprised at how discordant the marrow is in one part of the body versus another. And maybe, I don't know if he's had marrows on both sides or just one side of his iliac crest, but either that or an anterior approach, if there's some confusion about what the marrow is really showing in this case. It doesn't look like, though, he has an elevated blast count either in the blood or in the bone marrow. So it does sound something like it could be immune in the background. But again, he doesn't really have the very high hectic fevers or high ferritin or high levels of the other things, high LDH and so on, that one typically associates with HLH.
Was an EBER performed?
Dr. Zahra,
What?
was EBER performed?
No, we don't have it. No.
No? Okay. Got it. Dr. Muhammad Awad,
Yes, I have a comment here. I think we have to search for rheumatologic disorder. It could be macrophage activating syndrome, macrophage activation syndrome in association with some rheumatologic disorder, which can also result in secondary myelofibrosis.
I fully agree.
so it sounds like there's an agreement. Dr. Dua, to just summarize, to get them the criteria is not in like Dr. Gabolo was saying earlier, to get the criteria is not really to just check them off. There is a personality in HLH. There's a way of presentation that it doesn't seem like that's how it's presenting here. The ferritin is not crazy high. The markers are just a checkoff, and the spleen is not that big. So it is enlarged, but it crosses a criteria, but it maybe doesn't fit. So I think with all the ideas that is presented, maybe if we look further, like Dr. Nuha earlier said, other infectious etiologies, possible immunomediated autoimmune processes is very well worth checking.
Can we owe it back to the AstraZeneca or?
Well, the vaccine, to blame the vaccine for the whole thing.
Yeah.
I have to say I don't have any experience with AstraZeneca's vaccine because, we don't have it here. I had one case of severe autoimmune thrombocytopenia post Moderna vaccine that needed TPO agonist after multiple other lines of treatment attempted and failed. But I don't have any experience with AstraZeneca to weigh in on that.
If it was rheumatological disease, wouldn't it improve on steroid?
So how much steroids did the patient get?
HLH protocol for 8 weeks. I don't know if you received cyclosporin as well.
Yes, he received cyclosporin for 8 weeks.
Did we check hepatitis C?
Yes.
It was negative?
Yes, was negative. HIV was negative. Hepatitis B was negative. Epstein-Barr virus and also cytomegalovirus was negative.
So, Dr. Dina, when you look at it, is there any improvement in the curves with any of the therapies that the patient received so far? Like, when you look at it, like, when you see the counts, was there any signal of an improvement? This is part that I know that it persistently stayed bad, but did it improve at all during the treatment?
No,
There was no periods of improvement
no
whatsoever.
improvement.
I think even if we suggest rheumatological disease, not necessary to respond to steroid. يعني some rheumatological diseases are refractory, some may need target therapy. So it is not, يعني, it can be therapeutic test, but not the ideal, يعني, to answer Manari. يعني. So we should, I think, for this case, for more proper outcome, or to detect the clue, to do further workup as agreed.
Excuse me, Dr. Noha, we do the immune markers, we do the rheumatoid factor, and anti-double strain, and they were negative also.
B-ANCA, C-ANCA, or other
C3,
tests.
C4, no, we didn't do a B-ANCA or C-ANCA, but
I think we should roll also TB, just sputum TB, further, even PCR for TB, other investigation. Because as agreed, I think يعني, HLH criteria is not fully fulfilled for this patient.
About TB, we didn't do tuberculin test or then Nelson, but the patient has no chest symptoms. There is no radiological finding in the CT
But
chest.
he has constitutional symptom. He has maybe this fibrosis, secondary fibrosis, or something. There is something.
Okay, after finishing the protocol of HLH, we started ruxolitinib, Jakavi, since 17th of July, and the patient show improvement. The last CPC of the patient, the total leukocytic count is 4, and the hemoglobin is 9.5. The platelet is about 18,000.
I mean, the thing is, like, ruxolitinib is, immunosuppressive as well. So it might work with a variety of things.
And platelet below 50 is not approved, as I know. يعني bacratinib okay, لكن ruxolitinib in platelet below 50. What do you think, Dr. Mohammed? Below 50, you can use ruxolitinib?
It's difficult because the ruxolitinib in itself is suppressive to the counts. But it's interesting, in the white count improved, but the hemoglobin and the platelet didn't really change. The platelets are still in the same range, right?
No, it increased. It always have been less than 10,000.
But it was 18,000, right? Like it's.
Yes, but he only يعني we 7 days only, and we started.
Yeah. So it's hard to believe that this is the effect of ruxolitinib, but the ruxolitinib itself can, if you keep giving it to a patient with low platelet count or hemoglobin, it might make the problem even bigger. But as Dr. Gaballa said, it works, as you know, on JAK2, and this pathway has immune consequences to it. So we don't know when we're giving this treatment, we don't know what are we treating right now is the problem. Even if there's an improvement, why is there an improvement? Is it just because of the immune suppressive effect, or is there some other process that is going on and we're masking it? That's the issue.
Yes.
Dr. Noha, I think ruxolitinib here was not prescribed for myelofibrosis. It was prescribed for refractory HLH or for an immunologic problem rather than for myelofibrosis in this case.
Yes, it's second line in the refractory HLH.
Yes, I know, but I didn't experience with very low platelet. So I want to ask, is it approved for this low platelet count?
Only give low dose, about 5 milligram only.
Like the dose used in GVH يا دعاء مش كده? Like the dose used in acute GVH.
Yes, 5 milligram only. We didn't give him the full dose of ruxolitinib.
Okay.
Thrombocytopenia.
So could this syndrome be the rare syndrome of transfusion associated graft versus host disease?
I don't know.
Is the patient received transfusion before this presentation?
Yes.
But he has constitutional symptom.
Yes.
If it is transfusion associated, it will not cause the
constitutional symptom.
Transfusion-associated graft versus host disease could come with constitutional symptoms, Dr. Noha, I think.
But I guess the question is, why did he get a transfusion in the first place? Like he presented with the anemia and thrombocytopenia and then got the transfusion, right?
Yes.
Yeah, not the other way around. Not like he got a transfusion and then his counts went down, correct?
Correct. Yes.
I think from history, the best history only AstraZeneca vaccine.
Yes, then after 1 month,
in the present history.
the constitutional symptoms, yes.
Also, keep in mind that transfusion-associated GVH is rare in most of the world. It's most common in Japan, where there's relatively homologous HLA types, and so the relative cross-reactivity between T cells that can engraft and cause it is higher. Also, this causes very severe pancytopenia and very severe peripheral reactions in the GI tract, skin, and liver, which this guy doesn't have. So it's unlikely that that would be the cause.
Oh, okay.
Yeah.
Yes, I agree.
Yeah, did we check like a B12 folate? I know that those usually would present with, macrocytosis and hemolysis-like picture, but did we check them?
Sorry, I didn't hear.
B12 and folic acid?
No, we didn't check it because he presented with normocytic normochronic anemia, not macrocytic, so we didn't do it. Or we had plastic changes in the bone marrow, so we didn't ask for it.
Yeah, no, yeah.
Dr. Higazi.
Oh, Dr. Mabad, welcome, Dr. Muhammad Nasser. He's the from bone marrow transplant at Frisco. Thank you for joining. Thank you. I'm good. Alhamdulillah.
Hello, everybody.
Yes.
Dr. Muhammad, let me be sure from this point that all these troubles followed the AstraZeneca vaccine. I'm not sure from this point, but is that the case? Correct me if I'm wrong.
Dr. Dua, is that correct? Is 1 month after the vaccine, correct?
The booster dose of AstraZeneca vaccine, yes.
1 month after the booster, okay.
Okay, but for sure this patient has this hemophagocytic manifestations. But the problem is why? So we are looking for the cause, right? And there is some possibilities, some autoimmune disease, some malignant disease, hematologic disorders, and infections, right?
Right.
So what you recommend as more investigations?
If I can summarize some of the ideas mentioned from the rheumatological workup, maybe adding a Pianka, Cianca, looking for a TB from infectious. Dr. Emmons mentioned about next generation sequencing. I know next generation sequences is not widely available in Egypt, but in case something picks up in the marrow, to guide us a little bit about an underlying T cell or other malignancy that is not caught. Images, I believe, Rob, you mentioned the MRIs can sometimes guide in that regard.
Just when there's confusion about the sampling of the marrow, if there are sites that are very fibrotic versus others that are more marrow filled, you can pick up the water density versus fibrotic density differences. And sometimes that can make a difference in terms of the result you get from doing a marrow when there's some discordant problem. I don't know if this guy's had, for example, trauma to that area, because that can sometimes cause necrosis and damage in the marrow that leads to an impression of fibrosis when it's just a local issue, not necessarily a systemic issue. Obviously, infections can play a role this way too. TB was also mentioned already, but there are other systemic infections that can sometimes affect the marrow and cause problems. But autoimmunity is certainly a very good point in terms of the workup for things that might cause that and splenomegaly.
Peripheral blood flow might be helpful. I don't know if that was done or not.
And also the CT scan for CT scan done or not, Dr. Dua?
Yes, the PET-CT was done and showed only splenomegaly about 14 centimeter and only benign reactive axillary lymph node, nothing else.
Yeah.
How do you know it's benign and reactive lymph nodes?
They have certain criteria. I don't know.
Yes.
They can
What's,
be able.
what size
know.
were they?
They said they changed some.
Yeah.
It was about
the
1
anatomy.
centimeter with preserved criteria. And we also do ultrasound on the axillary lymph node, and it was reactive also. There is no any malignant criteria in the axillary lymph node.
See, it's a very difficult case, I have to say, and unclear what's going on, but very difficult case and an interesting discussion. Is there any other questions before we?
They can continue for more investigations to try to find out what the reason. But the question is about the treatment. They have to stop this protocol for HLH, or they continue, or what they can do.
Okay, that's actually an excellent question. I would like to hear what others say, because I have some opinion on this, but I would like to hear what
can we perform another bone marrow biopsy? Maybe something will show up, maybe.
Yeah, but I think a guided bone marrow biopsy rather than a repeat, a repeat biopsy again for the third time, just in one spot again might not help. So, but I wonder what Dr. Awad, Dr. Gaballa, and Dr. Emmons think of. Now the patient is on treatment for HLH. What would you do now?
We have another question from Dr. Atif asking about the value of PET-CT in this case.
I don't know if the PET-CT is going to guide if we don't have a whole lot on the CT itself. This it might help. We are grasping on straws here, so it might help. But the CTs have not shown. But I agree with Dr. Mustafa. It might be worth it to take another radiological studies, repeat, and see what happened. Has things changed over the time in terms of treatment?
Dr. Muhammad, what do you mean by the guided bone marrow biopsy?
So just like Dr. Emmons was mentioning, if we get an MRI and we have areas that seem more filled with marrow than others, that will be able to give us a better marrow sample, because the marrow sample, as you see here on the pathology with our pathologist's presentation, it's pretty empty. We're getting some lymphocytes, and some plasma cells, but nothing clonal on those plasma cells either. But in my opinion, since Dr. Gaballa and Dr. Emmons haven't weighed in yet, I think my approach would be to support the marrow rather than to beat it up further. Meaning, if in this case we need to find a diagnosis, we need a diagnosis and treatment right now. In my mind, I know what are we treating, so I wouldn't treat. The only thing that I can do is support the bone marrow, meaning things that does not have a major consequence to the patient's overall condition, especially if this is an underlying hidden infection that is causing this. Further treating as HLH is not going to do us a lot of good, but giving TPO agonists might help the platelet count and stimulate the bone marrow. As you know, these markers, something like iltrombobag, might help lower the transfusions and maybe stimulate the whole bone marrow. I would not, again, I think it's a very difficult case, and it's hard to keep holding yourself from starting a treatment, but also treating without being 100% sure of what we're treating might make the picture even muddier.
Yeah, Dr. Mustafa was wondering if we can have fine needle aspiration of the lymph nodes if they are persistent, even if they are radiologically benign.
They're very small, 1 centimeter, right?
Yes.
Yeah, I'm not sure you're gonna get much out of this. I mean, I agree with Dr. Higazi. I would probably stop the treatment and maybe consider doing a bone marrow biopsy, maybe from the other site, or you could get an MRI and look at what's the best spot. I would probably add like an NGS to it, next generation sequencing. It is available in Egypt. I've had someone do it recently. It's done on the Tarif Hamza. But you need I'm not totally convinced this is HLH.
Okay. So without further, going on with this one very difficult case, can we move on to the next one to discuss the next presentation? I know we already spent 48 minutes on the first one. It was worth it.
Yeah. I'll share my screen.
Yes, please.
Good day to everyone. I'm Manar Hamid, Assistant Lecturer of Medical Oncology at Oncology Center, Mansoura University. I want to thank Dina Farahat because she made this PowerPoint. Okay, this case of a female patient, 31 years old, was presented with abdominal pain, night sweats, and night fever. She had no medical history apart from being HCV positive and receiving direct-acting antiviral treatment. She had a surgical history of open heart surgery, and it was corrected when she was 1 year old, and no family history. CT neck, chest, abdomen, and pelvis showed bilateral suprarenal masses. The largest was on the left side, measured about 13.7 centimeters in the maximum dimension, and on the right side, it was 4 centimeters, plus multiple para-aortic lymph nodes. Largest was 13 millimeters. Clinically, there were no peripheral lymph nodes, and his lab tests showed normocytic normochromic anemia. LDH was very high, 948, and the bone marrow aspirate and biopsy were normocellular, no abnormal deposits. One was from the right suprarenal gland mass, and it was lymphoma diffuse large B cell, positive CD20 and BCL2. CD3 was positive in the reactive T cells, CK was negative. So the patient received cycle shock plus 2R and fecal CNS prophylaxis, and CSF analysis was free. PET-CT post 6 cycles R-sharp showed we have 3 lesions. The only one which was active was the left suprarenal. It decreased in size. It's now 4 centimeters, but its SUV was 3 compared to the liver SUV, which was 1.8, while the para-aortic and the right was entirely okay. So trial for EUS and the fine needle biopsy from the left suprarenal gland unfortunately failed. There was no evidence of lymphomatous deposits in the center specimen. Okay, before discussing this case, I want to say that for the case, because both of them share very common characteristics, if you don't mind. This is a case of female patient, 22 years old, who was presented with abdominal pain as well. She had no surgical, medical, or family history. Triphasic CT showed the left adnexial solid lesion. It was large, measured about 19.5 in the maximal dimension, plus moderate to marked ascites and mild left-sided pleural effusion. And radiologically, the conclusion was mostly fibroma, ovarian fibroma, plus Meigs syndrome. The aspiration cytology from the ascitic fluid was lymphocytic with occasional atypical cell. Aspiration from the pleural effusion was inflammatory. Axillary neck and inguinal ultrasound showed subcentimetric benign looking lymph nodes. His lab test CBC was normal, LDH was 1600, beta HCG was normal, colonoscopy and upper GI and post-breast ultrasound also were normal. So the patient was explored as a case of possible ovarian fibroma. She underwent right salpingo-oophorectomy and the left ovarian mass excision as a trial for fertility preservation. And the diagnosis was bilateral ovarian malignant round cell tumor consistent with non-Hodgkin lymphoma diffuse large B cell, positive CD20, CD10, BCL6 was positive in more than 30%, and it was negative CD3, CD99, and the TDT. PET-CT post-operative showed the left ovarian mass, the residual, had high SUV, 9. Post-operatively, there was a trial for oocyte preservation, but unfortunately, it failed. So the patient received the 6 cycles R-CHOP plus Zoladex, and the PET-CT evaluation showed this left ovarian mass now had SUV of 3, and it measured about 4 centimeters. So,
Dr. Manar, Zoladex is what? What's Zoladex again? Just because of the brand name. I'm sorry. Zoladex is what is it? What is the drug? Oh, for ovarian suppression. Okay, got it.
So, the reason why I want to discuss these 2 cases because I want to discuss some basic issues. First, what is the role if that has a residual lesion? What is the role of surgical excision? And if it is proved to be a non-Hodgkin diffuse large and we completely excise it, do we have to receive second line or we can follow up?
Yeah, Dr. Muhammad, I could take this one. Okay. Yeah, so not uncommonly with diffuse large B-cell lymphoma, especially if you start out with a very big mass, you're going to have some residual tumor that's actually scar tissue. And the question here is there any residual, disease or not? So for the first case, the SUV went down to, was it 3 or was it 4?
4 centimeters, yeah.
No, 4 centimeters. What was the SUV at the end of
3?
3. Okay, and what was it in the beginning before? Before treatment, what was the SUV initially? That diagnosis.
Okay, just 1 second. She didn't do PET-CT prior to starting treatment.
Okay, no problem. And the liver SUV was just
1.8.
1.8?
Yeah.
Okay. There's probably like a dual score of 4. So I mean, for those cases, and if the SUV was very high in the beginning and it went down by more than 60-70%, then it's technically still a CR. Here we're not so sure. So what I would personally do is, now initially it was 11 centimeters, right?
Yeah, the left side was 11.4 and the right side was 4 centimeters.
Okay, so you have 2 options here. I mean, it was bulky disease to begin with, so she's probably in remission. But if you want to do consolidation radiation to the area that was initially more than 10 centimeters, that's an option. The problem is I don't know if it's in a good location or not, because it sounds like it's in the abdomen and there's going to be there might be a lot of collateral damage from the radiation to this area. So, typically what I would do is I would discuss it with the radiation oncologist. And if we think it's going to be, she's going to have too much long-term side effects from the radiation to this area, then we would just monitor it. Now, the question is she in remission now or not? So she's probably in remission. The dual score of 4, I think this is just because it was, such a huge mass to begin with. But it went down significantly, went down from 11 centimeters to 4 centimeters. So typically what I would do for these cases is just 2 months later, just get a CAT scan, not even a PET scan, just a CAT scan, and make sure it's shrinking or it's stable. And that it's not, it's not getting bigger. If it's getting bigger, then yeah, you need another biopsy, and that's not good. But at this point, I would not do any more any more treatments. Your second question about surgical excision, there's not going to be any role for surgery. I mean, you know, because it's a systemic disease. It's not a solid tumor. So you know, even if you take it out, and if there was still active, you know, lymphoma in there, it will show up somewhere else because it's in the blood. So your options are, you know, you do the treatment, and then, you know, if she goes into remission, which we think she might be in remission, the question usually is, do you do consolidation with radiation or not? What was your other question?
Okay.
Was surgical excision?
CNS prophylaxis, I think, was another question.
Yeah, so CNS prophylaxis, what's the best approach?
Yeah.
Nobody knows. Okay? But for her, it sounds like, you know, so she has like it's like what, an adrenal mass?
Yeah.
It was yeah.
Yes.
So this is the high risk for CNS involvement. So typically what we would do is we would do the R-CHOP plus 4 to 6 intrathecal methotrexate. We used to give more high dose methotrexates at day 15, you know, either 2 to 4 cycles. But the problem is, you know, more data is now being, you know, showing that it doesn't really, you know, matter that much. And nobody knows if, you know, you really need the high dose methotrexate if it's just for prevention. So what I would do is just intrathecal chemotherapy for between 4 to 6 cycles. Now, this patient did not get 6 cycles of rituximab. She only got 2, right?
Yeah, with CHOP, but she continued R-single.
So how did it do? How did you do again? How was it done again?
She received, yeah. For expense issues, started the R with the 5th cycle CHOP, and after 6 cycles CHOP, she continued R-single for a total of 6 cycles.
Oh, I see. Yeah, and this was like an insurance problem or something?
Yeah, something like that.
Okay.
What about lenalidomide or ibrutinib? Do we have a future for it in CNS prophylaxis?
For CNS prophylaxis, no. I mean, you know, there was a maintenance lenalidomide trial looking at post-treatment, especially in older people, and that didn't, you know, show much benefit. There was maybe the Germinal Center, actually, they had like a better PFS, which was opposite to what we were thinking. But no, for ibrutinib, so, you know, ibrutinib is being reused in primary CNS lymphomas because it crosses the blood-brain barrier, but, you know, it's not something that will be on label or approved, and we definitely don't use it for CNS prophylaxis.
Okay, so what do you use as your standard of care for fertility preservation in such young patients?
So fertility preservation is usually a problem in these young patients coming in with aggressive lymphomas, because typically you don't have enough time to do like the oocyte collection and all that. I mean, if they do, which almost always is not the case, and they have like, you know, 3 to 4 weeks for the oocyte collection, sure, you could try that, but that is almost not always the case. So typically what we do is just like, you know, ovarian suppression, just you're doing either birth control or you know, what you used with the LHRH, but there's no, you know, there's no one standard. So a lot of times we don't do anything.
Okay. I guess you answered the last question. For the suprarenal, we can follow up for 2 months and then repeat the CAT scan.
Yeah,
and the ovary case, what would you do?
So remind me again, what was the question for the ovarian case?
What's your further management?
So she's in, you know, the end of treatment PET showed that she was in remission now, right?
Also, she had the left ovarian lesion with SUV3, measured 4 centimeters, low-grade metabolic activity.
Yeah, but it shrunk significantly, right? It was much bigger before.
Yeah.
What was it before? The size? What size was it?
Well, she the left was not that huge, but post-operatively, she had SUV9. Now SUV is 3.
Okay. And what's the liver SUV?
Also 1.8.
Okay, so she's kind of a similar thing. And you also don't have a, you know, like, I'm sorry, what was the size initially before the surgery?
Okay. And the left side was 19.5.
Oh, wow. Yeah. Yeah, I would just repeat another CAT scan in 2 months.
Okay. Okay, thank you.
Thank you very much. I think that's exactly what I would be thinking. I don't know if Dr. Emmons or Dr. Awad or Dr. Mabed would like to weigh in on either one of these 2 cases.
I think routine follow-up is reasonable. There's a question of with a high-grade lymphoma, if there's a background low-grade lymphoma that might be sort of dogging some of this issue in the ovarian realm. So the small signals could end up being something a little bit different that might come back to haunt later on. But certainly follow-up with CT is very reasonable, as was suggested.
Agreed. Agreed. Dr. Nasr, yeah.
But before doing follow-up with CT, she has initially bulky disease. Do you think she will benefit from consolidation therapy?
Consolidation,
to the initially bulky lesion.
Consolidation with what? With autologous
radiotherapy. No,
radiation. I think the radiation is something, as Dr. Gaballa mentioned, it would be a consultation with the radiation oncologist and see how much damage would they think because of the location of the lesion, what would be the best approach there. Both of them have a very low activity in terms of what you would expect in a post-treated DLBCL refractory disease. Won't be an SUV of 3, but a very close follow-up might be needed. I think it needs the multidisciplinary approach of a consultation with them, seeing how things were before and after, and radiate only if the damage was not going to be significant. In my mind, the problem is with the radiation therapy in the young lady is it's almost very likely going to lead to even worse chances of any kind of fertility. While in the other case with the suprarenal, I think it's all risk and benefits there.
In our everyday experience, I think this initially bulky lesion will not be cured by R-CHOP. I have never seen patients with this initially bulky lesion that have been cured with only 6 cycles R-CHOP, especially in the presence of residual.
I think it's reasonable. It's a reasonable concern. That's for sure. That's for sure. It's a very reasonable concern.
Can we do mutational analysis, c-MEC and BCL2, BCL6, especially in this bulky diseases? If it is proved to be double hit or triple hit, it will be sure that R-CHOP not curative for this, because they are aggressive, young age and aggressive and bulky lymphoma.
Very true.
Even double expressor lymphoma, we should do c-MEC expression and BCL2, BCL6 if mutation analysis is not there.
I agree with you that we need to do them as it's a good prognostic test. R-CHOP ×6 is already given, so we are past EPOCH versus CHOP discussion, and I would like to hear what Dr. Gaballa would like to say on this topic.
Yeah, so nobody knows what's the best way to treat a double or triple hit lymphoma. That's the bottom line. Our EPOCH is not any better. You know, there's a lot of data now showing that, you know, even, I mean, for a while we used to do more our EPOCH But more recently, with the data that was like last ASH, it doesn't seem to be much different than R-CHOP. So the bottom line is for those double or triple hit lymphomas, if they respond after 6 cycles, they're gonna do okay. So there was there was a paper a few years ago that showed that if you have a double or triple hit lymphoma that goes into CR1 after 6 cycles of R-CHOP, they do very similar to other diffuse large B-cell lymphomas. The problem with the double or triple hit lymphomas is if they're going to act up, they're going to act up from the beginning. They're going to be refractory to treatment. And those ones, there's nothing that works for them, even CAR T.
Okay, I mean, if we tested even for mutational expression and proved it to be double or triple hit, we can consolidate with auto in CR1. They are young age, high IPI score, and high CNS relapse, and high risk criteria, bulky disease. It can be an option, and auto in CR1. It can support this idea.
You can consider it. I mean, you can consider an auto transplant for double or triple hit lymphomas if they achieve CR1. But again, it's a controversial issue.
Okay.
I personally, I wouldn't do it. It hasn't been proven to be to add the benefit, especially with also the young patients. You're putting them at a mortality risk there, but it is reasonable. I don't think it's a standard of care though.
Yeah, there's no standard for these double hit lymphomas, so you could.
Dr. Mabed,
yes, I do agree. But if we want for more investigation to assess the risk criteria for this patient, if it has more than one item that suggests a high risk lymphoma, would you suggest, I don't know, the consultation with auto transplant?
In CR1?
Even in CR1?
If we call it CR1, yeah, that's the point of that Dr. Noha just mentioned. As I said, we don't typically, unless we believe that this is residual disease that warrants further treatment, we don't go for an auto in CR1 regularly, at least in our center. Dr. Gabala in Moffitt, and they do a lot more, so he can weigh in what they do over there in CR1 and high risk lymphomas.
No, so we don't take any more. We don't do any auto transplants for CR1.
Shouldn't we try to have a biopsy from this SUV3 lesion?
Is it easily accessible?
No, especially the suprarenal one.
Yeah, I mean, it went down from, it was very big, it got smaller. The SUV is not that high. That's why I'm saying usually we don't do CAT scans in 2 months. Typically we do a CAT scan in 6 months. So there is a question here if it's residual disease or not. That's why I'm suggesting to do like a closer follow-up than usual. Obviously, if this is something that's super easily accessible, but it doesn't sound like that's going to be the case, then yeah, you could do a core needle biopsy there to clarify what's going on.
Okay, one final question. We had a colleague of mine want to ask a question. She had a stage 3 non-Hodgkin lymphoma case that she saw last week. It was stage 3S, and after 6 cycles R-CHOP, there was only splenic focal lesion. Then the patient underwent splenectomy, and it was proven to be non-Hodgkin diffuse large B. But the patient went follow-up. Yeah, was that the right thing to do, to follow up, or should he receive second line as it is a systemic disease?
So wait. So this patient has stage 3 diffuse large B-cell lymphoma, gets what, 6 cycles of R-CHOP?
Yeah.
Okay, and then the spleen has residual diffuse large B-cell?
Yeah.
Yeah, so this is the case where, so this patient will not do well. These are the cases that have been approved for, for CAR T recently, because even if you do salvage therapy followed by an auto transplant, your cure chances are probably, 15 to 20% at best. But I would not do observation at this time. A few months from now, within a year for sure, new lesions will pop up elsewhere.
Yeah. Okay. Thank you.
But the question now in this patient, should we go for salvages in auto or consolidate with auto? We have no residual now. We do not have any residual. We go for consolidation with auto, or to give 2 cycles of salvage therapy and then to go for auto.
How quickly could you go for the auto?
Immediately. She has residual disease after 6 cycles of R-CHOP. She is not in CR after 6 cycles of R-CHOP. She must be consolidated with auto. But my question, do you prefer to go for auto directly or to give consolidation therapy, RDHAP, for example, and then to go for auto?
Yeah. Now, I mean, so the point is, we want to take them with auto with the least amount of disease. So now, what's the last PET scan showing? Is there any residual disease anywhere?
Only residual.
Well, he did a splenectomy. He did a splenectomy, and nothing else was done after that. No PET CT was done.
Can't see anything anywhere else?
No, it was the CT, normal CT. There was no other lesion.
So that's an interesting
prior to splenectomy was active spleen. So he did a splenectomy and didn't do PET again.
I see. That's an interesting question, actually. So, Dr. Higazi, do you think we could go for auto straight and skip the like an ICE or DHAP cycles? Or I've never done it.
Yeah, that's the thing. We don't do that. We always take them to ICE if there is any evidence of active disease, because even if we don't see it, we believe that there's something somewhere that has not responded to the initial therapy outside of the spleen. It's just we see it yet. So we still, I know this case is very interesting because you took out whatever is residual on the PET scan. So is there anything else elsewhere? I still might give them our preferred regimen is more like our ICE. So we would give them ICE and then 2 cycles and then collect their stem cells after it to go as long as they are still in remission. But then that also brings the point of CAR T. Then you don't need any salvage with CAR T, right? Like you just take their T cells and go for it. With the current data, but of course the CAR T I believe is still developing in Egypt, and hopefully it will be there in the very near future.
It's still not developed, so
yeah.
I totally agree with you, Dr. Higazi. I think this patient should be consolidated with 2 cycles of salvage, and then she has to go for it. Yes.
Yeah.
Okay, can I ask a final question? So the patient receives the 6 cycles R-CHOP and then progresses. What is the value of adding R to the DHAP or the ICE?
No value, Manar, no value. She is refractory to R, yes.
So primary refractory, like no response at all?
Yes.
Yeah, these patients don't do well with whatever you do, so.
But for our patient, she responded. She just has a residual. She is not totally refractory. She responded.
Yeah, I mean, if she had a partial remission, then you might give her the benefit of the doubt and do the rituximab as well. We typically do the rituximab.
Okay.
Yeah, agreed. That's we also do rituximab. Okay, any other comments from our panel? From us, Dr. Emmons. I truly appreciate all the presenters. I thank you very much, Dr. Duaya, Dr. Zahra, as well as Dr. Manar, as always. And I truly appreciate all the faculty for joining us today. It was a very interesting conversation, and we might need to hear more about that first case to see if it if you end up finding a different diagnosis down the road. And inshallah, you know, I was planning on presenting a case, but we'll present it next month along with Dr. Al-Quran, who will share the pathology.
Okay, Dr. Muhammad, thank you so much. And for the first case, we will try to look for a literature for the side effects of the vaccines.
Yes, yes.
Okay, okay.
Thank you. Have a good day.
Okay,
thank you. Assalamu alaikum.
Thank you. Next month.